So Dr. Anna Bujons is the head of Pediatric Urology at Fundació Puigvert in Barcelona and coordinator of Spain's National Reference Center for Bladder Exstrophy. She's deeply committed to patient advocacy and collaboration. Dr. Bujons works closely with national and international associations and serves in leadership roles across multiple professional societies. Dr. Bujons will be discussing stone disease within our bladder exstrophy population. Thank you.
Good afternoon. It's a true honor to be here with all of you today. Being recognized by ABEC Center of Excellence in Bladder Exstrophy is an immense source of pride for our team. But beyond recognitions, what truly matters is sharing this space with those who give meaning to everything we do, you, the patients and families. We come here to offer our experience, but also to keep learning from you. Every history, every challenge, and every achievement teach us and make us better. With you, without you, none of this would make sense. Thank you for allowing to be part of your journey. It's truly an honor to be, take part of the session that represents so much for the professionals. Before we begin with data or surgical techniques, I want to start here with what truly matters. This image reflects the health of our work children, adolescents, adults with exstrophy and their families. Thanks to organizations like ABEC, these families are informed, supported, and connected. So we are introduced about the stones and the long-term follow-up. So you know there are so different types of surgeries for bladder exstrophy. Some children have a bladder reconstruction, others need a bladder neck closure and a catheterizable channel, and some require a bladder enlargement with a Mitro to help empty the bladder. These treatments are chosen based on each child's needs. In the long term, some patients may develop bladder stones, especially those who have had a bladder made larger using augmentation, and who also had a bladder neck reconstruction or closure. This is why regular follow-up and bladder care are so important. We are a center of reference in exstrophy, and we follow these patients until their adulthood. As a result of our experience in stone disease and urology techniques, we wanted to link stones in bladder exstrophy and minimally invasive procedures together to improve in the care of our patient and long-term to minimize complications. Exstrophy patients have an increased risk of urolithiasis that has been known since the 90s, thanks to the work of Dr. Silver in 1997, who confirmed that the risk of stones in this population was 160 times greater than the general population, with an incidence of 25% in patients with cloacal exstrophy, 60% in bladder exstrophy, and 3% in epispadias. Once a bladder or renal stone is treated, the risk of recurrence appears to be high. Despite the high risk factors, particularly modifiable ones, remain unclear. Around 50%, as I said, from 50 to 25% of patients with bladder exstrophy may develop bladder stones. And why do bladder stones form in bladder exstrophy? Due to the bladder augmentation with a bladder neck closure and the creation of the catheterizal channel. However, the type of bladder, for example, this kind of bowel produce mucus. And if the patient doesn't do regular catheterization and a daily bladder irrigation, that mucus and urine can build up inside the bladder. This increases the risk of infections and stone formation. Bladder stones are the most common complication after this kind of surgery, and many children may need another operation to remove them, even in 5 or 10 years later. So when a bladder stone is discovered, it's important to treat. Why? Because the stone acts like a nidus or a focus, a place where no crystals, bacteria, and minerals can stick and grow. This means that if the stone stays in the bladder, it can get bigger or lead to the formation of more stones around it. So that's why we recommend removing it properly before it causes more problems like infections, pain, or blockage. So in our center, we wanted to know what are the recurrent risks, for example, for factors for lower urinary tract and upper urinary tract in this kind of patients. And our objective was to determine what the factors are that raise the recurrence of lithiasis events in bladder exstrophy patients. From our call that the more than 150 patients with follow-up more than 20 years, 35 patients have presented a lithiasis event that we have followed since the first stone surgery with a mean age of 8 years. 40% of our patients had native bladder. 20% of them had colonic conduit because they are all with the reconstructive surgery done in the 80s. And 66% had bladder augmentation. 48%, for example, have mitral FANOF, and 45% had bladder reconstruction or bladder neck closure. There are different ways to remove bladder stones depending on each patient's situation. For example, endoscopical removal. A small camera instruments that pass through the catheterized stoma, and we use that for stones less than 1 centimeter. Percutaneous approach, when the patient needs or have more than 1 stone and more than 15 millimeters of the size of the stone. And operative surgery, it is the last option, used only when other techniques are not possible or have failed, because there are many complications, such as vesicocutaneous fistula. So we can see the patients had kidney stones and patients with lower urinary tract. So most of the treatments in the upper urinary tract is in the kidney, where with minimally invasive procedure. In the kidney stones, the main procedure was PCNL, and for the ureteral stones, the procedure was anterograde uteroscopy because most of the patients have reimplantation. And for the lower urinary tracts, it's for bladder stones, the main procedure was via channel, and in case of the size was less than 10 millimeters, and for percutaneous cystolytotomy, we see several lithiasis of more than 10 millimeters of size. The mean time between the reconstructive surgery and, for example, for bladder augmentation and the first stone in the kidney was 23 years. The recurrence was in 66% of the cases. On the other hand, the median time, the reconstructive surgery in the lower urinary tract, where the appearance the stones in the bladder, the was 8.5 years after the reconstruction. And the recurrence was more than 80% of the cases. As you can see, the median time of recurrence of the stone in the kidney was 44 months, and the bladder was earlier in 1.5 years. In the most cases, bladder stone in patients with bladder exstrophy do not happen just once. We often see the timeline like this, for a stone appears a few years after bladder augmentation, average more than 5 years. Many patients experience a second or even third stone within the next few years, and the recurrence is often linked to chronic infection, poor emptying, and mucus buildup. So what is the stones made of? In our analysis, almost 90% of the stones were made of struvita is associated with infection. What increased the risk of a stone coming back? Based on our experience, the main factors that increase the risk of stones is with a heart, a bladder reconstruction, bladder enlargement, and a mitral FANOF. So the risk factor we can see, exstrophy in exstrophy Epispadias history, independent risk factor for bladder stone formation after augment and cystoplasty, the bladder neck closure, the recurrent UTIs infection, and the poor compliance with the ECC. Patients who are non-compliant with irrigations have more probability of bladder stones recurrence. So how do you standardize the prevention of a stone recurrence? So to standardize care, it's important to maintain an active attitude toward bladder irrigations. A scheduled annual follow-up with imaging tests to detect possible recurrence early and analyze also the stone composition, which can help identify and prevent these risk factors. So remember, accumulation of mucus in the urinary reservoir acts as nidus for bladder stone formation. So the importance of bladder irrigations to clear mucus and ultimately prevent bladder stones. High volume bladder irrigation with normal saline has become the standard to prevent bladder stones, bacterial colonization, and symptomatic UTIs. Our institution, we advise patients to perform high volume irrigation daily after bladder augmentations. Sometimes it's 3 times a day. So compliance to the irrigation remains an issue, and it is difficult to assess compliance after the patient leaves the hospital, especially in the teenagers. Here, for example, we have a summary of the prevention strategies. So it is important to mention that some groups can recommend intravesical antibiotic instillations, for example, gentamicin, in a patient with frequent infection. This is not a part of our standard protocol, but it can be used in certain centers as a preventive option. So managing bladder exstrophy and its long-term complications, such as bladder stones, require more than just surgery. A multidisciplinary team includes urologists, nurses, radiologists, nephrologists, nutritionists, and psychologists, helps provide a comprehensive care. So to conclusion is the treatment of coronary the high volume daily irrigation and timely CIC catheterization are the best measures to prevent bladder stone formations and recurrence. Interventions to prevent bladder stones are crucial, as the majority of bladder stones formed will require several stone surgery and their lifetime. Thank you.